Hello everyone, my name is Varun Hariharan, and today I'll be presenting our case report titled When Esophageal Erosions Mimic Behçet's Disease, Could It Be Pemphigus vulgaris? Pemphigus vulgaris is a rare but serious chronic autoimmune blistering disorder that primarily affects the skin and mucous membranes. The disease is mediated by IgG autoantibodies directed against desmoglein 3 and in some cases desmoglein 1. These desmogleins are adhesion proteins that help keep keratinocytes tightly bound together. When the autoantibodies interfere with these adhesion molecules, the keratinocytes lose contact, a process known as acantholysis, which results in a painful erosions and blister formation. The incidence of pemphigus vulgaris is quite low, estimated at only 0.1 to 0.5 cases per 100,000 individuals each year, so it's not something clinicians encounter often in routine practice. Most patients initially present with painful oral erosions, and over time they may also develop involvement of other mucosal sites, such as the conjunctiva, nasal passages, genital mucosa, or eventually the skin. However, esophageal involvement is particularly uncommon. When it does occur, it can mimic more common conditions like reflux esophagitis, infectious esophagitis, or even inflammatory conditions such as Behçet's disease. Because of this overlap, the diagnosis can be delayed, which significantly increases morbidity and prolongs suffering for the patient. Our patient was a 38-year-old woman with a medical history of type 2 diabetes and prior gastric resection for peptic ulcer disease. She presented with 1 week of persistent hematemesis, severe odonophagia, substernal and epigastric pain, and an inability to tolerate oral intake. On admission, she was tachycardic at 119 beats per minute, her potassium was low at 3.4, her CRP was elevated at 2.9, and she had significant ketonuria, findings consistent with dehydration and poor oral intake. Importantly, this was not her first episode. Earlier in the year, she had been hospitalized twice for very similar symptoms, including odonophagia, dehydration, and small volume hematemesis. Because she had also had painful oral ulcers and a history of genital lesions, her outpatient rheumatologist had suspected Behçet's disease and discharged her on colchicine and a low daily dose of prednisone. During her current admission, an esophagastroduodenoscopy showed a diffuse erythematous and friable esophagus with mucosal sloughing and bleeding. A biopsy was deferred at the time because of bleeding risk. At this point, multiple consultants were involved. Dermatology felt the lesions were not typical for Behçet's. Rheumatology raised concerns about the absence of systemic vasculitis. Ophthalmology confirmed that there was no ocular involvement, which is an important feature usually seen in Behçet's. In addition, the patient reported a history of blistering under her arm and erosions on her scalp, both of which are not typical for Behçet's. Given this constellation of findings, an oral mucosal biopsy was performed. Histopathology revealed suprabasal acantholysis and direct immunofluorescence showing intracellular IgG deposition. Together, these findings confirmed the diagnosis of pemphigus vulgaris. Once the correct diagnosis was made, treatment was escalated. She was started on high-dose intravenous methylprednisolone at 30 milligrams every 8 hours, later transitioned to oral prednisone at 60 milligrams daily, and she received her first inpatient infusion of rituximab. Supportive therapies were also initiated, including pantoprazole, sucralfate, chlorhexidine, and lidocaine rinses, antifungal agents such as fluconazole and nystatin, analgesics for pain, and nutritional supplementation. With this regimen, her odonophagia gradually improved, but her oral ulcerations and weight loss persisted. Repeat endoscopy continued to show diffuse mucosal friability. She was ultimately discharged on a tapering course of corticosteroids, scheduled outpatient rituximab infusions, antifungal prophylaxis, and nutritional support. Now let's step back and discuss why this case is important. Esophageal involvement in pemphigus vulgaris is rare, but carries major clinical consequences. Endoscopic findings such as diffuse mucosal friability and sloughing can look almost identical to more common diseases like reflux, candidal infection, or Behçet's disease. The overlap means that pemphigus vulgaris may not be recognized until late, which can result in repeated hospitalizations, severe malnutrition, electrolyte abnormalities, and persistent weight loss. The management of mucosal predominant pemphigus vulgaris requires systemic immunosuppression. Corticosteroids remain the cornerstone of therapy, but rituximab has now become the standard of care for inducing remission and limiting long-term steroid exposure. Supportive measures, antifungal prophylaxis, mucosal protectants, aggressive nutritional supplementation, and adequate pain control are just as important to improve quality of life and reduce complication. This case emphasizes 3 major teaching points. First, pemphigus vulgaris should remain on the differential in patients with unexplained mucosal ulcerations and esophageal disease that does not fit a typical pattern. Second, the disease can be easily misdiagnosed, particularly as Behçet's disease, which highlights the importance of early biopsy and direct immunofluorescence to establish the correct diagnosis. And third, multidisciplinary involvement with gastroenterology, dermatology, rheumatology, and ophthalmology is critical to reaching the correct diagnosis and guiding management. Thank you.